So good evening, everybody. Good evening, everybody.
Good evening, Joy.
It's good to be here this evening. And it is indeed my pleasure to introduce to you our speaker this evening. Our speaker, Jonathan Quick. He's a family physician and health management specialist. He is the president and CEO of Management Science for Health, MSH. He's an international, which is an international non-profit organization with teams in Africa, Asia, and Latin America. MSH builds local capacity to achieve greater health impact through stronger health systems. Jono was Director of Essential Drugs and Medicines Policy at the World Health Organization from 1996 to 2004. Prior to that, he served with MSH as founding director of the Drug Management Program for Pharmaceutical Management, then as a long-term advisor for the Afghanistan Health Sector Support Project and the Kenya Healthcare Financing Project. Quick has worked in international health since 1978 and has carried out assignments in over 50 countries in Africa, Asia, Latin America, and the Middle East. He is the senior editor of Managing Drug Supply, co-author of the Financial Times Guide to Executive Health, and has written over 70 other books, articles, and chapters. He's on the faculty of Harvard Medical School, Department of Global Health, and Boston University School of Public Health, and now chair for Global Health Council. He has a first degree from Harvard University and an MD with distinction in research and Masters of Public Health from the University of Rochester. Jono has moderated leader seminars for the Trinity Forum in Boston, Brussels, Geneva, and Montreal. With that introduction, I have the pleasure to introduce our speaker this evening. Please, you are welcome. Let us use the remaining energy of the day to listen to some of the wonderful things he has to share with us this evening. You're most welcome.
Thank you. Thank you, Joy. I'll tell you, I don't know how many people have been to South Sudan, but I think it's the area about the size of France, 10 counties, 10 million people. And at least as of a few years ago, when you drove around Juba, the capital, about a quarter of the time you were driving on tarmac, the rest of it was dirt road. And as soon as you left Juba, you were on dirt road through the entire rest of the country. It's a really tough place. And we were just talking beforehand about the challenges of resources and doing things there. But I mean, talk about the Spirit of Christ in action and courage tested. So it's good to have you here in Washington. So thank you. Let me start with three thanks to CCIH. First of all, thank you, because it's really nice at least once a year to be able to talk without a coat or a tie and put some jeans on. The second thing is Pauline's, it was sort of a mix between a sermon and an activist call to action. I spent 10 years across the hall from UNAIDS or down the pathway and hadn't quite realized that we had a theologian and an evangelist there. But my second thanks is actually 3 years ago, as often happened, in January I got an email, and it was from Henry Mosley and from Laura Van Vuven saying This is when we were looking at the Millennium Development Goals, and when I talk about women in the Millennium Development Goals and all, and it sent me on an incredible journey through the Bible. We'd been going to a church which, after we'd been there 3 or 4 years and couldn't figure out why they couldn't find any women to be elders, we realized that actually that's the way they read their bylaws, and they couldn't be elders. As a result of doing the talk on MDGs and women, I mean, I knew things were bad, but when you actually get into the data, I mean, when you look at the data and you say, what is the biggest discrimination in the world? Economic, ethnic, religious, it's gender. It's everywhere. And that 60% figure of 60% of AIDS in Africa is women, women and girls, that comes from 4 basic inequities. Education, 2 out of 3 children not in school are girls. Economic, only 20% of women in Africa are at stable employment, which makes it vulnerable to the sugar daddy phenomena and all that. Personal power, by some surveys, 50% of married women in Africa and Southeast Asia do not have a say in major personal health decisions. And finally, knowledge. Boys in Africa are much more knowledgeable about, that's part of the education. Boys are more knowledgeable about AIDS. But the last thing is violence. There are 5 kinds of violence, and Pauline knows this well, 5 kinds of violence that are specific categories of violence that are uniquely or primarily directed against women. And you can imagine that if there were 5 kinds of violence that were uniquely or exclusively directed against men, they'd be doing something about it. So anyway, long and short of it is that I said to one of the elders, I said, you know, the Jesus I know, I cannot believe that he had anything but total equality in mind. And the elder responded that it doesn't matter what you think, it matters what the Bible said. So I went on a quest for the best book. And actually, there's a great book on Amazon, 2 Views on Women in Ministry, which is a classic old-style debate. 2 academics pro, 2 academics con. The thing that's interesting, in the 2nd edition, the editor got the writers together for a lunch. They crafted a statement. These are 2 strongly egalitarians and 2 strongly traditionalists. Those are the kind of terms that they use. And they basically crafted a statement saying, we all believe what we started believing, but we recognize that people who believe in the literacy of the Bible and are reading in good faith can come to opposite points of view. It's basically a scriptural standoff. And so I finally went back to the elders. I bought them all a copy of the book and wrote them my analysis of it. Needless to say, they didn't agree. So with 3 daughters and a wife and not even the preponderance of evidence, I mean, it really is a scriptural standoff. I said, with this much inequality in the world, I'm not going to be on the slippery slope. So finally, it took me a while to actually resign, but I got a chance to do it at a church meeting. I was actually invited. They at least were open-minded enough to let me tell people about it. And the final point on that, the tenaciousness of opinions, I got an email officially rebuking me from one of the people in the church, and I thought about it. It was actually very, very vigorous, and you know, hellfire and all that. And I wrote back and I said, Tom, well, you know, my reading of it is it's a scriptural standoff, and I said, I'll pray for you, and we'll meet each other in heaven and find out who's right. So anyway, the third thing I want to thank CCIH for is just another wonderful conference, and I think Paul and the board and Ray and the staff and all do a wonderful job, and it's great to see the new logo and the progress and just the continuing momentum at CCIH. So thank you for that. I won't read the whole list because I'll get somebody wrong, but you know who they are. So switching gears. Last week, there was an unreported landing of a space vehicle in a Bavarian forest and in the southwest of Germany. The spotters located it, and it was in a place near a secret retreat that's used for presidential, when the presidents and prime ministers of Europe have to have a special secret and secure a meeting. They have it there. Well, this spacecraft landed there. It was from Mars, and the Martians came out, and they requested to meet with President Francois Hollande and with Chancellor Angela Merkel. And they said only the only communication was that we want to talk about the health problems of Europe and North America. So Angela and Francois said, well, we better get Barack on the line. So they did, and they conferenced him in. And the Martians said, you know, we've been looking at Europe and North America, and we see that you have a big problem. You have an epidemic of heart disease, you have an epidemic of cancer, and you have an epidemic of diabetes. So we are proposing to fully fund a major response to that. And what we are proposing is the Galactic Fund to fight heart disease, cancer, and diabetes. So Francois and Angela and Barack conferenced together, and they said, wait a second. This business, the Martians, the other part of it was the Martians said, in order to make this really efficient and results-focused, we're going to set up separate supply systems, separate training programs. We're going to have separate health workers and separate facilities and separate communications programs for heart disease, for diabetes, and for cancer. But we'll pay for it all. So Francois and Angela and Barack are meeting together, and they say, wait a second. We don't have enough warehouses, enough trucks, enough supply systems, a big enough information system. We don't have enough health workers. There's no way that we can set up the three parallel programs. We're going to, because we particularly in France and in Germany, they're very much into primary care, and they really like the idea of an integrated health system. So they said they politely declined. They weren't sure how the Martians would take it, but they politely declined, and the Martians went back to Mars. So what's the point? 2000 was an amazing tipping point for global health, and we have had a whole cascade of initiatives that have been hugely beneficial in terms of combating AIDS, TB, malaria. Family planning hasn't done quite as well, and maternal and child health have actually progressed pretty well. But going into the next decade, what we've done in these programs is basically we've built quite a siloing of the different programs. And when we get into countries, there's some synergies, but there's also a lot of separation. And whenever we talk about the chronic disease epidemic, which is dwarfing AIDS, TB, malaria, and maternal deaths combined, it's really interesting because it's actually like talking about gender problems a decade ago. Donors sort of look at the ground and shuffle their feet because they don't know what to do with chronic diseases. So how do we, in a world where we still have short resources and a different epidemiology and a different set of problems, how do we move forward? So here's one vision. Anybody want to guess who wrote this and when it was written? Sorry? Amata? Other guesses? Could the Marshes have written it? Do we need it now? Do we need comprehensive care, community orientation, cooperation with the governments on all of this? Actually, you were right. This comes from 1968. And I want to take us back in time a little bit. And you'll see this come around full circle. But if we look back, in the early 1960s, we were just a generation into modern medicine. In World War II was the first time we had widespread use of antibiotics and vaccines and really were able to benefit from, well, that was when it started, and that was precious little. And even in World War II, we couldn't make enough penicillin. We had to recycle it from urine. It's true. Over the next generation, we created a huge amount of medicines, vaccines, and by the 1960s, we had prevention and treatment for the major killers, but more than half the population in the world wasn't benefiting. And so at this point, there began where we had a lot of ability to treat, but it wasn't getting to people. The mission started talking, and there were concern had been that they had been building hospitals and clinic-based care, but they were basically, as they said, repair facilities. They did little, if anything, to address causes of illness. And the Christian Medical Commission was established in 1968 by the World Council of Churches to really look into that. 25 members from diverse countries and all. And that process eventually made a major contribution to health for all. And one of the people who, let me see if I can get this. Okay. One of the people who we know well here, I don't think he's here this year, Jack Bryant. Jack is not here this year, I don't think. Was he here last year? Yeah. Okay. So how many of you know who Jack Bryant is? Okay. So he was really, and you may remember his story from 2008. He was really behind two key thought streams that led to the Christian Medical Commission. One of those thought streams was looking much more systematically at health in developing countries. And with a grant from the Rockefeller Foundation, Jack produced Health in the Developing World in 1969 and became first chairman of the Christian Medical Commission. So one stream of thought was looking at health much more systematically in developing countries. The second stream of thought, which led to the creation of the Christian Medical Commission, was the theological basis for health and healing. And I think Pauline would be a good contributor on this. But there was a series of debates in 1963 and 1967. I think the Martians are back. I'm going to chat for a little while, but did we disconnect something? Wait a second. Is this? This isn't supposed to be in, is it?
I don't know.
While you work on that, let me just pick up. So there was a real consideration of trying to get a Christian understanding of the meaning of health and means of healing as part of the essential Christian contribution to medical service. And so for the first couple of years of the Christian Medical Commission, they really looked at this whole question of mission service and how the Christian community serves in the countries that it's in. That led, at this time of great inequity with the services, that led Jack as the chair to really begin talking about health as a human right, about natural rights, social justice, and he proposed three principles. Whenever health services are available, They should be equally available to all. The second, departures from that equality of distribution are permissible only if those worst off are made better. And finally, there should be a floor or minimum of health services for all. So basically, back in 1968, they were laying out the principles of access, prioritizing vulnerable populations, and essential services. The other thing that CMC did back then was to explore 3 community-based approaches around the world that got people focused on what could be done at the community level. One was in Central Java, one was in Chimaltenango in Guatemala, and the third one, you know where well. Is Connie here? Yeah, okay. What's the third one, Connie? Jomkid, yeah. So these programs were strongly community-based, reached out beyond health, and they actually became some of the proof points for Alma Ata. So when Jack was here in 2008, he summarized the contributions of CMC, listing 4 main contributions. The focus on healthcare systems needing change. The second, bringing people together of diverse groups. The third, providing these country-based examples. And the fourth, reflections on perspectives of both theology and health. So Alma Ata, in 1978, really CMC and the Christian movement, mission movement, was a major force in terms of the values and philosophy of that. Now, let me switch gears then. And instead of doing, the themes are similar. So last week, Pauline and I and about 4,500 other people were in Malaysia, in Kuala Lumpur for Women Deliver. And the theme that we actually talked about a lot of different things during that week, but our theme was, the theme that we were really talking a lot about from MSH's point of view, was universal health coverage as a women's issue. And there's skeptics and enthusiasts. For those of you who have been tracking, and where this was going with the Alma Ata setup is actually when you look at the language that's going on now with the debate on universal health coverage, it's very much along the language and values of health for all. And so we're coming to 2015. A lot's been achieved, but with a very focused way. In a sense, it's parallel to what 20 years ago we said selective primary health care. I mean, it was a little bit segmented out. The question has been, what will be post-2015? And a lot of us have been arguing strongly that it should be an essential element is universal health coverage, and it's particularly essential for women. We fail 300,000, we fail 200 million women each year who can't get the family planning they need. We fail nearly 300,000 who die in pregnancy and childbirth. We fail 700,000 women who die each year around the world from breast cancer and cervical cancer alone, 70% in developing countries, where women die younger and faster, where prevention is almost non-existent. So when we talk about universal health coverage, they're the enthusiasts and they're the skeptics. And the skeptics say it's not possible, that it won't help women, and there's nothing you can do. It's not possible. Ask Dr. Siddiqui, the Minister of Health from Afghanistan. In December 2000, when a very conservative government was chased from power, there were basically no female health workers active anywhere in the country. Immunization had fallen to less than 20%. And 9 out of 10 women delivered without a skilled birth attendant. 9 out of 10 women were on their own. Dr. Siddiqui could have said, we're going to build hospitals in the cities because that's politically appealing. She didn't. She said a vision for universal health coverage with a focus on women and girls. And we had a great privilege and Sally Craig was out there, Douglas was out there. We had the great privilege of working with her to realize that vision by setting up an essential package of health services, which actually is exactly the language in the U.S. Affordable Care Act, essential package of health services. Afghanistan set up their essential package. They trained thousands of community health workers, half male, half female, and trained hundreds of community midwives from the community that they were serving in, and meant to go back and serve it. By 2010, family planning had doubled around the country, reaching some rates that were higher than some countries in the region that had been at it a decade or more. 150,000 fewer infants and children were dying each year, and maternal mortality had gone down by 2/3. That was a vision of universal health coverage. The argument, it won't help women. You can't see her, but Lucy Sakala was an MSH colleague in Malawi. She was an AIDS counselor. You may have remember me talking about her last year. At a fairly early age, she was diagnosed with cervical cancer. And when she would counsel patients who had tested positive for AIDS, she'd say to them, live positively. I do. There's some things worse than AIDS, like cancer. Lucy couldn't get treatment in Malawi. The best she could get in Zambia was too little too late. And she died at age 28, leaving a husband and a wonderful 8-year-old daughter. If Lucy had lived in a country with universal health coverage, she could have gotten simple, affordable screening for the cancer and quite possibly curative treatment if it was early enough. If she had lived in Rwanda, which a very visionary minister of health, okay, now we got a time question. We'll try to put it all together. So you've just heard this. This is Afghanistan. So you've heard that. Let's see if we can. Okay. All right. Let's see if we can put it back together here. So this actually looks a lot like universal coverage. The term universal was used in the Alma-Ata Declaration. This is actually from last December, December 2012. Actually, let me not leave you hanging on Lucy, because I'm not sure. Yeah, we'll get back to it. Sorry. Okay, we'll come back to Lucy. So this is what actually the UN, with sponsorship of many different governments, including the one of this country, put together. And what's interesting is that it's got the universal, it's got the essential package, it's got the medicines, it's got the affordability. It's the Alma-Ata phrase was much more concise, but you get the point. And it's got the emphasis on poor and vulnerable. So there is momentum gaining for the whole idea of universal health coverage. We've been at it 130 years. So, I mean, it's Germany was the first one to get us going, and then Universal Declaration of Human Rights opened the door for that. UK, Thailand, Alma-Ata was a major one. And we're picking up now, it's accelerating. Very interesting. So this is the resolution I just read. 3 weeks ago at the World Health Assembly, Dr. Jim Yong Kim, the president of the World Bank, he ended his speech there with 3 musts. And that one of the musts was, we must be the generation that delivers universal health coverage. And then we'll come back to this. Last Thursday, the high-level panel that is working on this, on the post-2015, came out with their view, and we got some work to do. That's where we're headed with all of this. Just a couple of things on universal health coverage, and I'll try, in the interest of time. There's some common core principles. Prepayment, so you're not charging people when they get sick. Risk pooling, so that the rich pay the poor and the healthy the sick. And priority health needs. So it's not just about cure, and it's not a voluntary thing. It needs to bring everybody together. A lot of the talk that we hear about universal health coverage is focusing on the finance part, but countries have lots of different ways in which they approach that, and delivery is even more important. Some countries do it with a big bang. Some countries do it with a progressive approach. But always the vision, the end point, is reaching everybody, and you build the system differently if you have a vision for everybody. That was Dr. Siddiqui's idea. I mean, they're going to get some hospitals, but she was building for everybody. I'm going to skip these two examples. Let's just spend a minute on Ghana. There are 50 countries who are already at or close to universal health coverage. So the question, it's impossible. It is possible. Lots have done it. Ghana's working on it now, and they have got a mixture of funding sources, and that's part of what countries do. They're getting everybody, including the chemical sellers, and that's important because in low-income countries, half or more of people's out-of-pocket spending is for medicine, so getting that covered is important. This is a messy one, but this is the percent of out-of-pocket spending. That's what kills people. 150, well, between medical impoverishment and financial catastrophe, it's 250 million family households a year that are significantly, dramatically impacted by their health expenses. So you want to reduce out-of-pocket spending, and Ghana's been able to do that in increasing coverage. So it is possible. And this is the map. The ones in the darker colors are ones that are already moving, that are either claiming over 95% coverage. You got to watch about self-reporting. Or this is 75 to 90% the lighter. The blue are those who are implementing, who are starting to get going. So one of the questions is, who's going to pay for all of this? And one of the dynamics that's going on, during the period that we were melting the economy of the North from 2008 till, if you're still living in Greece, the present, while the high-income countries were melting in their economies and not growing at all, this is the map of Africa during the period of our financial crisis. The countries that are as light as Chad or darker were growing at least 3% per year, which for the economic growth is significant. Those as dark as Congo or darker were growing at 6 to 10% a year. And so whenever you have countries growing, they always increase their health expenditures. And so growth fuels health spending grows the health system, and so this is economic growth. This is the projected increase in health expenditures. Nigeria is going to quadruple in the next decade, Thailand triple, Bangladesh triple, Kenya more than double, and those. So as the economies of emerging markets are growing, money's going into health, and the question is, are they going to grow? With all due respect, I grew up in the U.S. health system. We have a wonderful medical system, but we've grown a health system with the sort of, without a universal coverage model, we've grown an unaffordable health system. It's a great medical system, and that's the risk in countries. If they grow their health system, if their economy grows and it grows a health system in a chaotic way without a vision of universal health coverage, it's going to be a lot of money poorly spent. So a bit on universal health coverage. In terms of UHC for women and girls, we began talking about that And this is Lucy Sakala, who passed away. And Lucy wanted her story to be told. And the last part that I was getting to when the light came on, if she was in a country of universal health coverage, she could be getting the early screening and prevention. If she was in Rwanda, where the Minister of Health has committed to universal access with the cervical vaccine, the HPV vaccine, she may never have gotten that cancer. And this is actually the deaths per 100,000 women from cervical cancer, about 70% preventable with the vaccine. The darker it is, the higher the rate. So the point is, there are more women dying in low and middle income countries from just breast cancer and cervical cancer than there are pregnancy and childbirth, by a fair bit. But if you listen to the news or look at the health system, you could be forgiven for concluding that poor women don't get cancer, because nobody's paying attention. That's changing, but that's just an example. This is a tough slide, but it's actually very revealing. This was, there's a countdown group that's looking at the delivery of the Millennium Development Goals for women and children. And they've looked at a whole range of different services. And they've looked at coverage in 5 quintiles. Those are the richest 20% of the population. Those are the poorest 20% of the population. Here's the 50% coverage mark. So if you look at it, with measles and DPT, which are focused, they're boy disease, they're girl disease, there's a lot of focus. On average, over 70% coverage, and not much difference. Actually a fair bit of difference between low income and high income. But look at antenatal care. The average coverage is about 50%, but the lowest income, the poorest 20%, are way down here. The richest are way up here. Look at family planning needs. Again, half the need met. But the poor are way down here, and the rich are way up here. And look at skilled birth attendant. Whew, look at that. I mean, the poorest 20%, it's almost as bad. I mean, basically 2 out of 3 women are on their own without a skilled birth attendant in the poorest 20% for these 54 countries. So, and the point being that there is a real distinction between what the poorest are getting and what the well-off are getting, and it really hits women harder. This is Akita from Uganda, and it is wonderful to go to a very old, broken down, dusty-looking health center in Uganda, in eastern Uganda, in Budaka, and see that they're doing screening, that the AIDS clinic there is also doing screening. She had a positive screening test for cervical cancer. She didn't have to go to Kampala. She went up to Mbali close by and was treated. And as far as we know, she's out of the woods in terms of cancer, so cervical cancer. So the report of the high-level panel came out. This is a group of, it's a great title, it's a high-level panel, humble name, high-level panel of eminent people, eminent persons. And they actually did better than many of us feared they might. They had an overall vision which was good. There was some debate whether they would have squishy goals or more concrete ones. They kept the goals, they kept the idea of concrete goals with some indicators. That was pretty good. And one of the 12 is healthy lives. The feeling all along was that health getting 3 of the 8 Millennium Development Goals the first time around, we kind of won the lottery, and we may not get so much this time. So we were happy to get 1 clear goals that's expressed in terms of healthy lives, which is actually pretty progressive. But they're suggesting under that some indicators. Preventable child deaths, that's good. Immunization, interestingly, they're talking about full lifespan immunization. So cervical cancer's on there, and I mean potentially. And the whole idea is global goals but national targets. Maternal mortality there is good. Universal sexual and reproductive health rights, so it's there. We don't have to come back and fight for it after the fact. And then the burden of disease, and they did get non-communicable diseases on there. The problem is that they waffled a bit on universal health coverage. It's not one of the goals, and it could be, because you cannot achieve, in my reading of the data and the experience, you cannot achieve these in a sustainable way without this. And this they've left as an, oh, by the way, something that needs to happen, but they're not putting it up at a goal level. So, in conclusion, 3 points. I would heartily endorse Jim Kim's view that we really could be the generation that gets universal health coverage going. Universal health coverage is the only approach that addresses all of the needs of women and girls. Chronic diseases, infectious diseases, and sexual and reproductive health, and can do it in an integrated way. And finally, Health for All through UHC should be really a foundation for all the health goals. And so I think we didn't get a chance to talk much about Carl Taylor, who was also part of the CMC. But I think the basic values that the Christian Medical Commission laid out that fueled Alma Ata can go into, this is a campaign that we and others, that MSH and Rockefeller Foundation is doing in Africa. And the theme was chosen by the people from the countries that were involved. So it is Health for All in a different setting for universal health coverage. So we must be a generation that can deliver, and universal health coverage is the one approach that'll hit all the needs of women and girls. And I would hope that we've got, in the 2 years that we have to really, between now and when the post-2015 goals are adopted, that we will in our own settings advocate for that. So thank you, and happy to have some questions, but thank you.
Looking at the time, I would invite a number of questions, a few questions for our speaker. First of all, we want to thank you very much for reminding us the movement as it has come all the way from the Almata up to today. And we want to give an opportunity to the House to ask or to make a few comments before we close. Yes, Ray.
Jono, in these various high-level consultations, do you ever find participants who represent the faith community in a visible way?
I actually haven't been at the consultations, so I don't know. What we're trying to. There are different groups that are involved. There's a group, Global Health South, which is several hundred NGOs from the South. So I don't know, but I would absolutely encourage you to be there, because you can be there, and there are going to be multiple opportunities. September is an important opportunity because there is a discussion around the UN General Assembly, and so that would be a good time to get the message out. There are multiple opportunities, and I would engage, absolutely.
Any other?
Thank you very much for the wonderful presentation, and also for reminding us where we're coming from, and also trying to reinforce the message regarding the role that the faith-based community has played with regard to healthcare across the globe. I just wanted to ask you a question. You mentioned something about promoting universal health coverage, and that health for all should be the foundation for that. But then I do realize that in most of the sub-Saharan countries where the faith-based communities have established healthcare facilities, there is a user fee that is charged. And then we've had policies that are trying to discourage, that are trying to promote equity in access to healthcare through either provision of free healthcare services so that we can achieve the health for all. And then that, of course, it has had some challenges. And African governments, for example, have been called upon to increase their health allocation to the health budget, like the Abuja Declaration. Now, I'm just wondering to say, with the universal health coverage, where I think the models are a bit mixed, I'm not saying how equity in access is going to be addressed there, because I'm afraid to say that in situations where we don't have a health insurance, what are your recommendations? And then, what would be the message to the faith-based communities, that are faith-based organizations that are already doing a wonderful job in the communities, but they are struggling with provision of free health services because governments are not subsidizing their healthcare provision, and increasingly they have to depend on donations, and we all know that donations are not sustainable. Is there anything that you can recommend to us? And then, is there something that we can do as we're going to be lobbying for the post-2015 so that we are part of the solution, but we also ensure that what we started yields benefits and fruits in the next generation? Thank you.
Yeah, I think there are two things. They're at the global level, advocating to get universal health coverage into the post-2015 agenda. And do that through, I mean, we can talk more about where the connections might be and the leverage points to do that, but it is influencing each of the members of that high-level panel, but then the government consultations. At the local level, getting involved in the governance of these things. So, for example, in Kenya, there's a National Hospital Insurance Fund, which for decades, public health facilities could claim from that and use those monies to improve services. They never did. And the whole thing was run, everybody running that was appointed by the president. Finally, the law was changed, and the board now of the National Hospital Insurance Fund includes 13 organizations, half of which are, at least half of which are not appointed by the president, and it includes the Christian Health Association of Kenya, it includes the teachers, it includes the employers and all. So when we have the laws that create universal health coverage, you gotta get on the governing structure. And civil society can get there, and other people who have a stake in being sure that the services get delivered. And there's a wonderful example. 3 months ago, there was a wonderful case in which the chairman of the board of the National Hospital Insurance Fund said the CEO is fired because they're doing a lousy job. The rest of the board said the chair is wrong, he's still there. The permanent secretary said no, the chair was right. And then the prime minister said, hold it, you're all out. But that's democracy, you know, and that's having a voice, and that's transparency. So advocating for the laws and then getting involved in the governance. In terms of the financing, countries are going to do it differently, but the way Kenya's done it with a value-added tax, and they've got a health insurance tax, which is a value-added tax, and again, it's the transparency around how that's managed that'll make it work.
It looks like we have run out of time. Do you want to? Short. Nancy will make it short.
Nancy?
I'll make it really short. Yeah, short and sweet.
Jono sort of answered this, but not yet. Bono, the the personality has famously said that corruption kills more people than malaria. I don't see this working until we seriously attack corruption. And how are we doing on that?
Well, yeah, I couldn't agree more. But you don't attack corruption in theory, you attack it in practice. And so I think that more and more you are having governing bodies that that are composed of civil society and different parts, you know, the civil society, private sector, public sector, and transparency, shine the light. I mean, countries, yeah, it's a challenge, but there are countries that are moving on that, and we just have to keep beating on that. And the people in the country are more and more holding their governments accountable. But it's going to take time. But you can't do it in theory. So something like this, if people care about, it's a great way to push on governance, and that's a key part of the success or failure.
Okay, ladies and gentlemen, we want to thank the presenter very much. I think let us give him a clap. We thank him very much for reminding us where we are coming from and reminding us what needs to be done, what more needs to be done. Thank you very much, John.
Yeah, thank you, Jono. You've become a regular at our conferences. We value that. It's a couple of announcements. Dan and Doug, can you come forward? There's an interesting development that CCIH is a part of that I think will be of general interest to most people in this room. And so I've asked two of the leaders of it to just describe in just a couple minutes this initiative that we're working on, and I'm part of the steering committee to establish an online peer-reviewed Christian journal for global health. And the two of the leaders of this effort are here, Dan O'Neill from the University of Connecticut and Doug Fountain, who just came back from 9 years in Uganda, where he was at the Uganda Christian University. So Dan and Doug, just tell us briefly what this is about.
Good evening. We've been enjoying the conference. It's been wonderful. You know, some of the things that I heard from the conference is that, you know, there's a lot of good work being done in the name of Christ for the good of the poor, the good of the health of the world. But there's not a lot, maybe, of measuring and effectiveness, research of faith-based organizations. And part of our desire and our burden was to try to give a forum for people from the developing world who are doing a large majority of the health services to be able to both present research and extol the values that drive a lot of the work that we do. And that's part of the impetus behind the Christian Journal for Global Health. So I think, for example, like we spoke about the way that the value of training pastors to teach about the social justice issues and that lead toward health in gender-based violence as an example, and many other topics. A very broad-based, holistic view of health that we seek to promote, and we're just glad to have on our International Advisory Board Henry Mosley and Ray Martin and various other people such as Ted Lancaster and others from both China, India, and several from Africa. So, and an international advisory board. So, just wanted to give Doug an opportunity, who's also assisting with this project.
Okay. Yeah, thank you very much. And for reference, my name is Doug Fountain. I'm no relation to Dan Fountain. That's the most common question that I get. The journal, the Christian Journal for Global Health, is in development right now. As you've heard, it's an online open access journal. You'll be hearing more about it. There was already one announcement that came out from the CCIH newsletter, the monthly newsletter that came out. But to be clear, it's going to produce peer-reviewed articles, including evidence-based research, thoughtful reviews of social, theological, and other influences in global health, inclusion of many Christian traditions and perspectives, and submissions from throughout the world, where we're going to work very hard on that. And we had a lunch-themed table today where people were encouraging that we actually take a moment and make this announcement, because I think people were realizing it will be a significant development for all of us in the room. So I think we'll be following up with you all by email. Stay tuned, watch this space.
Thank you. Wow, it's been a really full day. I have a list of announcements, so bear with me. First of all, we're going to do another quick exercise. I want to try to recognize the number of countries we have represented in the room, and I forgot my fact sheet. But really quickly, just so you know, the fun fact for our live streaming, so our plenaries are being live streamed, and the person who is tuning in from furthest away is from Japan. So that's pretty cool. So that's exciting. Anyway, fun fact. So these are the countries I think are represented, and if I call out your country, please stand up. Rwanda. All right, yay, okay. Cameroon. Yeah. Democratic Republic of the Congo. Oh, where'd everybody go? Malawi. Yeah. Zambia. Oh, I think he left the room. Oh, no, there he is. Thanks. Uganda. No. Peru. Did she go downstairs? Sudan. Yeah, I don't know. Liberia. Oh, South Sudan. I apologize. Sorry, Liberia first. Hey, Liberia. Sorry. That's really bad. South Sudan. Thank you. Cambodia. Does it, count Cambodia? Okay. I think there's someone here from England. Where'd he go? There you go. I mean, I know you're not from England, but, England. Nigeria? Yeah, okay, yeah, you can stand for Nigeria. And I'm sure, the United States, would you like to stand? I mean, that's kind of weird, so let's not do that. Are there other, Canada? Oh, Kenya, Canada. Oh, sorry, I'm so bad. Oh, and I'm doing bad things to the slides. Kenya. Okay, who am I forgetting? Pardon me? Ghana. I didn't know anyone was, is that my bad? No? Oh, kind of. I love it. Represent. Okay. So if you work in those countries, or if you've done work in those countries, please go meet those folks. So that's kind of my public service announcement. If you signed up for Advocacy Day and haven't received your packet, please come see me after the group photo. It will be fun. On page 29, there is a map of a walk that we were supposed to do this morning, but because the weather was so iffy, we canceled. I will be going for a walk tomorrow morning at 6:45 a.m., and I am happy to have company. I will meet people right outside by where registration was at 6:45. It's the map that is in the book it's a little over 2 miles. But if you get tired, you just turn around and come back. And there is a short version and a longer version. So I'm happy to point that out to you. You will need comfortable shoes. It's paved, and then it becomes kind of wooded. So it's pretty, but please come join me. It will be lovely. Hesperian books will be for sale after this. Joel, where's Joel? Joel is there. Joel is leading worship and communion tomorrow morning, and he needs volunteers. So please go see him and help him so we can have communion during our worship time tomorrow. We would appreciate that. If you are checking out tomorrow, you must check out by noon, and there's a place to store your luggage, so don't worry about that. Right after this, we're going to have a photo, so don't go anywhere. And then after that, you get to go to dinner. And then after that, if you want to, there will be people hanging out in Raleigh Hall for games, fellowship, etc. Or you can have free time, and if you've never been here, maybe you'll want to go downtown DC to see the monuments or something. There's a free shuttle that goes from Marymount to the Ballston Metro, and you can go from Ballston into the city, and all the directions are on page 3 of your guide, and there are maps on page 47 and 48. So if you want to explore DC, please feel free to do that this evening and enjoy. And I don't know if I'm forgetting anything. Okay, but right now we want to have a group photo because it's exciting and we like to have pictures of everyone. So are you here? Is it okay to do it here? It's okay. So come on down to the stage, everyone, please. Thank you. If someone in the back, Liz, is that you? Could you go and make sure no, it's in the exhibit hall, please? Yeah, please.
Ladies and gentlemen, can you gather here and give me 2 minutes? I'll join you and I'll pose you, so don't worry.